Hi, I'm Shelley Wood, the managing editor at TCTMD, and this is On Record, a regular program looking at hot topics in cardiology and beyond. And we're in person. This is our first in-person video in 2.5 years. So welcome to my guests. I've got Nasrien Ibrahim and Shelley Zieroth. Thank you so much for joining me.
Thank you, other Shelley.
Thanks for having us.
Shelley with an E. Yeah. We're going to talk about heart failure because there's been new guidelines that came out at ACC 2022, as well as a lot of, this is a heart failure heavy meeting, ACC. Nasrien, can you start? What are some highlights from, I would say, March 2022, April 1st, 2022?
I would say for me, the thing I'm most excited about are the guidelines. The writing committee did a phenomenal job, and I want to congratulate them for the guidelines. They made everything really simple. There's lots of figures, lots of tables. They also created sort of a handbook for the busy clinician. So I really like how they put the document together, but the most exciting part for me was a figure with Class 2B, of course, no Class 1 recommendations for HFpEF. We look at ARNIs, SGLT2 inhibitors. So I think for patients with HFpEF, this is great news, maybe a light at the end of the tunnel for a disease that has been very difficult to manage. So that's the thing I'm most excited about.
Absolutely. Well, I covered the ESC guidelines, of course, that came out last fall, and it was, they came out within an hour of, I think it was Emperor
Preserved.
Preserved.
They
So
just
there
missed
was
it.
no recommendations, nothing new for the preserved HF.
The Americans were waiting.
Yeah, they were just wiggling their toes, yeah. But there's other things in there. The mildly reduced, that's in line with the ES guidelines. But what about this improved HF? Because the idea that you shouldn't back off on the meds, even as ejection fraction approved, that struck me as interesting. Is that something that would be useful?
Yeah, well, this guideline document really aligned itself with the universal definition of heart failure, which the co-chair of the guideline, Ibrahim, actually was the chair of that society-endorsed document.
Okay.
So that term came out a year ago, and now we have an alignment of the guideline document with the universal definition of heart failure, indicating those patients who improve their ejection fraction over 40%. And I think in the original document, it was greater than 10% increase, are considered improved. And based on some data from TREAD-HF, the recommendation is to continue disease-modifying therapy in those patients as long as they aren't having any adverse events.
Okay, great. I know you've got some highlights from ACC for us as well.
I do. Actually, I would also have to say, congratulations to the Americans for being the first ones to put out a formal HFpEF guideline on the SGLT2 inhibitors.
Yeah.
We've been waiting for it. They beat the Canadians, they beat the Europeans, right? And so I congratulated Ibrahim on that. And so I think that is the big news of this meeting.
Just that they've been incorporated, or that they're a 2A recommendation in reduced, and is it 2A or 2B? I don't have them at my fingertips, but
I thought it was
Is it 2B in HFpEF?
I thought it was a 2A in HFpEF.
It might be.
It's
Okay,
a
so
159-page document. I'm just going to say that there.
167 with the references.
Okay,
right?
well, it does seem that the information's there, and if we don't have it at our fingertips right now, it's because it's brand new. But so incorporation of the SGLT2 inhibitors is one.
Yes. And then there was also some value statements in that guideline document as well that I thought will be really important for administrators and regulatory bodies globally, frankly, in terms of, value basing the therapies that we have access to. The therapies available for heart failure now are increasing. It's a great time to be a heart failure cardiologist, I would say.
Right, but in terms of value, they're increasing in variety, but not in price. Like, it's quite expensive to get everybody on all 4 drugs, right?
It is.
But we're saving on hospitalizations.
Okay.
Patients are living longer, staying out of the hospital. We know hospitalizations are costly, not just to the healthcare system, but to the patient. It's burdensome. So I think when you think about the big picture, and I always say, you need to look into the venues for how to get these drugs at an affordable cost for patients. There's lots of patient assistance programs in the U.S. It's a big problem in the U.S. So there's patient assistance programs, and there's different venues where you can try to get these drugs at an affordable cost. But we have to think about the reduction in hospitalizations, the improvement to the patients, less burdensome, less symptoms, better quality of life.
Yeah. And it's all about shared decision making, right? And talking about the improvements that they could have.
Yeah. Okay, well, we could spend probably an hour talking about the guidelines, and I certainly spent many hours trying to understand them when I was writing my story about them. But as I was saying, there's other things at ACC, and I know you wanted to talk about sodium HF. You're a co-author on the paper.
Yes, during late-breaking clinical trials, there are actually 2 Canadian papers presented.
What?
Yeah,
They let us
taking
in.
over, but very excited for sodium. I was on the steering committee. It was led by Dr. Justin Ezekowitz and the Vigor Center, multi-international trial as well. And this really speaks to getting data about what we do. So in this intervention of counseling patients for reduced sodium, there was no reduction in clinical events.
Right.
So I think that was an important finding. However, we did note that there was an improvement in quality of life, KCCQ score, as well as symptom burden.
Right.
So, this is important when counseling our patients that, there is some impact on reducing your sodium. Overall, it's a healthy recommendation for all of us to reduce the sodium in our diets as well, to reduce the burden of hypertension and eventual heart failure. So I think, as a clinician, we will likely still counsel our patients that there are benefits to sodium reduction, acknowledging that it's not a reduction in clinical events.
Right. Okay. Because as I understand it, it's recommended that sodium is restricted in people with heart failure, but there's not a ton of data to support it. And in this trial, people were either recommended to lower or to go quite aggressive. Is that right?
Yes.
Mm-hmm. Okay.
Yes. So I think, there may be some modifications in the wording now that we have data showing that it's not a reduction in clinical events, but for improvements in quality of life and symptom burden.
Yeah. Okay. Any other highlights you want to talk about even outside the meeting? I do feel like everybody's been going on about the, what do you call your little badge, your glyphosinators or something?
Oh, the flozinator?
Flozinator.
Oh, I didn't even see those. I'm excited that it's NCAA Final Four this weekend.
It's a bit of a distraction.
The networking, we haven't seen each other in 2 years almost, so it's just been really awesome to see everybody. Just feels like you're coming home almost, like a homecoming to see all your friends.
I find my arms keep lifting in the air to hug people. I'm like, oh, no, we're not supposed to do that, but
I'm still hugging.
I think we're all hugging with our N95s on and lots of selfies. I was late getting here, right? Because I'm like seeing everybody in the hallways, and it's interesting. Not all of us knew that we were all going to be here, and we're discovering ourselves on social media. Oh my God, you're here! Let's go and see each other,
especially from Europe and
absolutely
in the Middle East,
it's
North Africa.
Yeah, no. Well, thank you so much for talking with me about all the heart failure stuff, and also for coming here and taking off your masks and speaking with me about it. It's really a pleasure to see you both.
Pleasure.
Thank you for having us.
And thank you for watching On Record.